Good morning, everyone. Welcome to our new International Risk Centers Symposium. We are pleased once again to have you all here as we continue the IWC Symposium series with many new centers joining us this year. Recently, the Mayo Clinic. We are very happy for this. So just to remind you, our webinars are interactive and practical. They aim to foster brainstorming and learning. So as usually, please, for all the attendees, feel free to post any comments, any question on the chat. We will try to answer all together during the session or after, depending on the time. So today it's our honor to welcome our friends from the IWC Mayo Clinic that are participating for the first time. And of course, from CLIMBA in Buenos Aires with Gustavo Gomez. We started this project together 3 years ago. So thank you, Sanjeev KAKAR and Gustavo Gomez for accepting to join this session with your colleagues and your team. Many thanks also to our speakers, David Chi and Diego Espinal, for preparing the cases we will review today. So thank you, Lorenzo Merlini, Lucian MARCOVICI, who are the co-moderators. They will guide us throughout the symposium. And we cannot forget Christophe Matoulin, Professor Matoulin, who is at the origin of this adventure. I see you, Christophe. How are you doing? Thank you for joining, at least for the beginning. He launched IWC in 2019. So we have 2 clinical cases today. We will start right now because we have 1 hour. We will start with a case from the Mayo Clinic. Once again, thank you all. And Sanj, please proceed. Give you the floor. Thank you.
Ahlam, thank you so much. It's a true honor on behalf of the hand division at Mayo Clinic to be invited here. And I'd like to thank Christophe Matoulin for the brainchild of this and setting this up, and really for Ahlam and Lorenzo's hard work with Lucian. And it's always good to be working with Gustavo as well. I do really want to thank our tremendous hand fellows. We could present 4 cases, but in the interest of time, we just have 1 today. And so I'd like to introduce our fellows. We have David Chi, who will be going to Brown University after this. We also have Lauren Tagliero, who will be staying on staff here at Mayo Clinic. We have Trina Stevens, who will be going to University of British Columbia in Vancouver, and Melanie Major, who will be going to Southern California. So it's been a privilege to have them with us. And without further ado, I'd like to introduce Dr. Chi, who's going to present a case of ulnar-sided wrist pain to get the juices flowing early in the morning. David.
Okay. Thank you very much, Dr. KAKAR. Wow, so many very famous cases today. But I have the honor to present a case presentation for my fellowship year. So our patient, he presented to us in 2023. This was a 41-year-old right-hand dominant man. He's a manual delivery driver, so he has to lift very heavy boxes throughout the day. And he presents in late 2023 with 1 month of right ulnar wrist pain after he sustained a work injury. Specifically, he was lifting a very heavy unbalanced box that tipped over and forced his wrist into hypersupination. And when we saw him a month after this injury, he says he has no pain at rest, but when he has to go into pronosupination, endorses 9 out of 10 pain. This is a workers' comp case because he has to lift many heavy boxes at work, and he's a very active gentleman with no prior injuries or surgeries to his right hand, and he has an overall relatively healthy man. On exam, the main clinical finding was that he had a positive fovea sign, which localized to where he endorsed his maximal point of ulnar wrist pain. Everything else was negative, negative synergy, no tenderness over the ECU, and also no pain on the ulnocarpal stress test. And he had a mostly stable DRUJ in comparison to his left healthy wrist. Some of his measurements. The main finding is that he has weak grip, and that's mostly limited by pain. Otherwise, his range of motion is mostly preserved and in line with his healthy side. Of course, we get wrist X-rays, and being a relatively young man, he he does not have any bony abnormalities. His ulna is roughly at a neutral variance. And so, of course, we move on to obtaining a wrist MRI. And so these are some of the key findings that we see. And so,
David, let me just want to ask Trina here, if that's okay. So Trina, you're seeing this patient, a young patient, manual laborer, sudden onset of pain after lifting a box, stable DRUJ, but tender in the fovea. When you're looking at the MRI, what are you thinking about?
Yeah, thanks, Dr. KAKAR. So, I will say actually on the lateral view on the X-ray there, I thought it was a pretty good lateral with the scaphoid and pisiform in the right alignment, but he's sitting a bit dorsal there with his ulna. So I know he's not. You're not able to elicit any DRUJ instability, but a 41-year-old is going to be a pretty strong guy probably. So I'm just wondering, when he's relaxed, if that's telling me there's maybe something going on at the DRUJ from a stability standpoint, seeing his ulna sitting so dorsal compared to the radius in that image. And then moving along to the MRI imaging, the first thing that my eye goes to is that axial cut again, because I'm thinking of whether there's a TFCC injury involved here. And again, on that axial cut, I'm thinking that the ulna is sitting a bit, not sitting squarely in the sigmoid notch. There's a bit of changes there, and then there's also a bit of fluid there. I'm assuming these are the T2 weighted images, David. Is that right?
yes, that's great.
Yeah, so I mean, I'm looking at some fluid signal in the sigmoid notch as well there. And then just kind of working my way around. So looking for any fluid around the ECU tendon. He wasn't really tender there, which is good. And looking at where the ECU tendon is sitting. And then kind of working my way across ligamentous structure. So, we don't have a really nice bow tie sign at his, on the coronal cuts. And it does look like
what is the bow tie sign, Trina?
Oh, pardon me. On the coronal cuts, looking at the TFCC, where it moves from its attachment at the distal radius and should kind of form a nice flare at the distal radius, taper as it comes through the disc portion, then flare again as it goes to its insertion at the on the ulna. So I'm not seeing that there's been disruption of that architecture. And then we also see the signal taper as it goes to the foveal insertion. So, these are all clues to me that there has been some trauma through that region. There's also, a bit of fluid at the foveal insertion. And then on the sagittal cuts, again, just looking for the ligamentous structures being disrupted. I'm having a bit of trouble kind of seeing what's going on here, but it does look like there's a bit of attenuation, maybe with that increased edema in the region. So I'm suspicious that there's probably something going on with the TFCC here.
Okay, excellent. All right, David.
Yeah, terrific. So those were the major findings that we also observed here. So on the coronal slice, we see that there's a likely tear in the fovea. On the sagittal, we see attenuation of the dorsal radial ulnar ligament. And then there is some dorsal subluxation of the ulna, as you can see.
So typically, if you go back there, David, typically we draw a line along the middle aspect on the axial view of the radius that should bisect in the middle of the sigmoid notch, and the ulna should sort of sit in the middle of that line. And you can see there's some dorsal subluxation there. So when you start thinking of seeing that, there's a paper by Kim Amrami and Dick Berger many years ago talking about potential foveal injury when you see that sort of MRI finding. Sorry, David, keep going.
Well, so given the constellation of his history and his physical exam, as well as the imaging findings, I thought we can open it up.
So Lauren, what would you do
how
here?
people might treat this patient.
There's 1 month out.
Yeah, so it's a relatively acute injury, so short-term pain. It sounds like he hasn't really tried any interventions for it at this point. So I think it's reasonable to counsel him for a trial of an injection and casting to start, some immobilization, just especially if his DREJ feels stable on exam, and see how that goes. Give that a trial for at least 6 weeks and then see.
So, Alarm, if this patient turns up in Paris, workman's compensation case, 1 month out, pain in the fovea, felt relatively stable. You saw the MRI findings. What would you and then we'll go to Lorenzo. What would you be doing in Paris? You're on mute, Alarm.
I'm sorry, do you hear me now?
Yes, now we can hear you.
Okay. Here we have all, to be totally honest, we have all the paraclinical and the clinical signs for a TFC injury here on the MRI. I will propose to the patient the surgical treatment because he's a young patient. He has the ulnar sided pain. There is probably not obvious clinical DRG instability, radioulnar instability, but we have some sign on the MRI. So for me, it's the typical case to propose to the patient an arthroscopic, a diagnostic, and a therapeutic arthroscopy, because it is the best case to check all the anatomical structures on the ulnar side of the wrist, not only for the TFC, for differential diagnosis. We can also have a central tear. We need to maybe to add a wafer. We need to check the lunotriquetral space and also the lunotriquetral instability. That's what I would say to the patient. We aim to we aim to treat the TFC, but we can have other lesions that we diagnose intraoperatively. Lorenzo, what do you think about this? Do you do the same?
I will probably stay on your side because I mean, I would certainly give both options to the patients, saying that it's a good time to do the surgical treatment now because we know that it gives usually excellent results when it's an acute repair compared to the fair but not so excellent result that we can obtain in a chronic injury if it develops. We can also try the medical treatment, of course. Injecting and splinting the patient could be totally fine. But I guess all in all, if I put everything in the balance today, given his age, his functional demand, and the fact that we're lucky enough to see him in an acute fashion and not 6 months or 1 year after the trauma, we'll probably go for the repair in first option. Yeah.
Okay. Gustavo, he comes to your office in Argentina. What would you be doing?
Well, I think that first of all, I think I really would like to check again the distal radioulnar joint stability, because sometimes patients comes to us telling us that they have an stable distal radioulnar joint. But when we have to remember that to test this, we have to hold not only the radius, but also the carpus. And then we have to do the ballonment test. And this is a pretty usual mistake that many surgeons and physicians do, to not to hold the carpus. So sometimes it seems to be stable, but when you do again the ballonment test, you can find some instability. So first of all, I will check again the stability of the distal radioulnar joint. If it is stable, I really would like to start a rehab protocol, because we are in an acute situation. First of all, I will try to immobilize the patient for 2 or 3 weeks, because we are in an acute situation. And then I will start a rehab protocol, because we have seen, and it has been published, that if you do some strengthening of the dynamic stabilizers, and I mean the ECU and the pronatus quadratus, before the surgery, and this patient goes to surgery with a good dynamic stabilizers, then perhaps you will have more successful after the surgery. So I think it's a good idea always to do rehab, and patients learn the exercises before the surgery. And sometimes you have to, the pain goes away just with the rehab, and you don't have to do the surgery because patients are usually with good stability. If you are talking about a partial injury, a partial tear of the foveal attachment. But if it is unstable and it doesn't goes well with rehab, I would like to do the arthroscopy as Ahlam and Lorenzo said.
Yeah.
I think the same as them.
Yeah, great comment. The only thing I would add in terms of the rehab is that we actually start the rehab from the shoulder down, because a lot of these patients have periscapular and scapulothoracic, weakness from their shoulders. So we start from the proximal distal. But I agree with you. And just one more opinion. He flies to Italy, and Lucian, he sees you. What would you do?
So thank you, Sanjeev. I need to tell you that 99% of my patients with TFCC tears are chronic patients, because I think in acute setting, this kind of injuries go very, very well with immobilization. I don't think six weeks for me, it's too much. I think that 3-4 weeks, like Gustavo says, it's better. And when you go and strengthen the dynamic stabilizer, they go really good. Okay, but we need to remember that some patients that have a really important instability, but I think those patients have already had some injuries of the TFCC or had a big trauma. Those patients can go into surgery in acute setting, but it's really a small percentage. Most of the patients with an MRI, like we saw in this case, will go very good with an immobilization and physiotherapy in an acute setting. And the patient that fail will be candidate to an arthroscopy treatment, in my opinion.
Okay, I think just in the interest of time, Ahlam, Lorenzo, we'll just keep going if that's okay. Yeah. Okay, David, we've got a lot to cover. Sorry, but good discussion.
Yes. So I think like many of our panelists suggested, we immobilized this patient for 6 weeks, and then after he came out of the cast, we did 6 weeks of hand therapy, specifically strengthening the dynamic stabilizers. However, after 3 months of this more conservative treatment, he still endorsed persistent 9 out of 10 pain with brought on by pronosupination. And so at that point, we then elected to take him to surgery to repair for a diagnostic arthroscopy and to repair injured structures, likely the TFCC. And then, of course, before that, he was going through the foveal repair rehabilitation protocol, so strengthening the scapulothoracic system, as well as the BR, APL, ECU, and pronator quadratus. And so from the MRI, it seemed very clear that he had a peripheral TFCC tear. And so with that in mind, we used the classification system first proposed by Dr. Atzi and Lucchini. And so with his findings, it seemed like it was most likely a class 2 or class 3. And especially given the acute presentation, we were fortunate to see him 1 month, now 4 months out before surgery. And so we expected, hopefully, that the quality of the tissue would be suitable for surgical repair. And so as we perform the diagnostic arthroscopy coming in through the 3-4 portal, we see the intact articular cartilage of the scaphoid and lunate facets, as well as the intact bulocarpal ligaments, as you can see here. And then moving ulnarly, we see that there's a synovitis right where the fovea sign, as you can see here. So that was later on debrided. And then while assessing the TFCC, we saw a positive trampoline test and mildly positive equivocal hook test and suction test. As you can see, the TFCC is lifting up, but but not coming up to the suction. Then to assess the actual fovea, we did arthroscopy of the DRUJ, so you can see the needle confirming that we are under the TFCC. And as we are in the DRUJ, you can see that the fovea, that the TFCC is lifted up as the fovea is torn, or at the insertion site. And of course, we can see that the DRUJ cartilage is intact. And so thus we performed what is known as the over-the-top TFCC repair. And so this is a relatively newer technique. And one thing to get used to, especially as a trainee, is the camera is now on the 6R portal, and then the straight needle guide goes into the 3-4 portal. And this allows the use of a K-wire with a nitinol loop, for which you can pass suture, fiber wire, suture tape through the passes, such that you can directly, through the camera in the 6R portal, you can directly visualize where the K-wire is going into the fovea, and then also coming out through an ulnar incision, protecting the DCU. And so with this, we were able to have 3 passes of 2O fiber wire, and then walking them down to the ulna. So here we have a video that will go through some of the steps. And so as you can see here, camera is in the 6R. The straight needle guide is coming through the 3-4, allowing passage of the K-wire over the top through the TFCC. And then coming out of the ulnar incision with the DCU nerve protected by a loop. And this allows the passage of one strand of the fiber wire. And the strength of this technique is through the camera, you can directly see where the K-wire is inserting, and you can ensure that you get a healthy bite of the TFCC. And once you have both passes, that allows you to tie a mattress suture down to the ulna. And then you can switch the camera back to the 3-4, and you can see that pulling down on the suture, you can see it anchoring the TFCC down to the fovea. And so for this patient, we were able to place 3 sutures. So the first one was middle, and then dorsal and volar suture. And as you can see here, I'll replay the video. There is a negative trampoline sign, and as well as a negative hook test, as we are unable to get under the TFCC now that it has been secured. And fortunately, a few months ago, we were able to see him back at post-op 1 year. He is now able to go back to work fully, lifting these very heavy boxes. And his grip strength has improved from 30 kilos to now 74 kilos. And he is demonstrating his maintained range of motion here. Oh, as well as the grip strength to prove his strength. And his injured side was the right wrist. All right, and so as a trainee, especially seeing the many panelists, there is a wide diversity of TFCC techniques. Each have their pros and cons, such as including the inside-out arthroscopic techniques. And so these are, as a trainee, these are some of the pros and cons that, as I see these techniques, that I kind of categorize in my mind. So with the bone tunnel, there is always a risk of fracture, and then it seems like as if the strength of tissue purchase can be dependent on the tunnel size. Suture anchor, if it's a poor bone quality, there's always a risk of pullout. And then when the variety in approach, so there's outside in, you're aiming big to small from the ulna into the the fovea of the TFC or the insertion point. And then inside out, which is what we demonstrated here, is small to big. And so you're going from the fovea out to the ulna. This is somewhat more of a recent development. And so, but these are some of the longest term outcomes of an inside out technique. And so Dr. Fujio had reported in almost 160 patients of a follow-up time of nearly 3 years that all but 6 patients had described significant relief of pain, and they were able to get back to 94% of the grip strength of their contralateral side. And so building on this is the over the top technique, which is, while the challenge is reorienting yourself to the camera in the 6R portal, the Fujio technique was using a curved needle guide for which you had to curve it just right into the fovea. But with the over the top, you can use a straight needle guide and directly visualize entry into the fovea from the camera in the 6R portal.
David, I think that was an amazing overview on that. Just in the interest of time, just if there's any comments, I want to be respectful for Dr. Gustavo Gomez's case. Outstanding job. Ahlam, you always have your hand up. Yes.
Thank you. No. Thank you. It was very, very good case. I think we all agree that we have many techniques to manage this. My only comments for the of the beginning is just I wanted to say, for me, practically in my clinics, when I have a positive foveal sign and positive ballotment test, for me it is enough to diagnose foveal tear, because I think the specificity and the sensitivity of the association of the two signs is very high. Just I wanted to tell you for practical things. That was the first thing. And for the surgery, I agree we can start with rehab, but be careful to discuss with the physiotherapist not to do prodosupination, because it's very important. And the sooner we operate the patient, the best. I think Lorenzo agree with me, because we know that there is a risk or a chance to operate the patient. So not 6 months after. It's better to make the decision sooner. Thank you. It was a very good case. If you don't have any other comments.
I have a question for Sanj.
Go
Sanj, yes. How it's a very nice and wonderful technique, this over-the-top technique, because you can have a very nice view of the TFCC, so you can choose exactly the place where you want to introduce the needle. But just for those that have no experience with this technique, what tips can you give us to find after you choose the right position over the TFCC? How do you direct the needle to find the foveal site underneath the TFCC?
It's a great question, Gustavo. And there was a recent paper in the Journal of Hand Surgery from Japan that did a beautiful biomechanical study actually saying that there's no true isometric point of the fovea. And where we thought the foveal tunnel is actually a little bit more radial than you think. So to answer your question, and I agree with Lucian, a lot of the patients that I see typically are chronic. And my goal, honestly, is to try and grab as much tissue as I can, because sometimes if you're truly being anatomic at the foveal insertion, the suture can rip out. And so for me, once you've debrided the fovea, and you can do that either through DIJ arthroscopy or you can make an ulnar incision, you know where the fovea is, and it's typically in the middle aspect as the camera's coming in. So I try and go in the middle of the fovea over the top, and then at least one passage of that wire has to be through bone. And then I will most likely come a little bit more ulnar, and that's either grabbing the peripheral side through capsule or through bone. We didn't have time to go over the biomechanics, but we found for instability, we needed to do 3 sutures. If it's just pain only, we would do 2. And there's one last comment that I'll say to Ahlam. This patient didn't have instability of the DIJ on clinical examination. but we know that clinical examination, the Bolotnik
Yes.
test varies widely.
Mm.
And so I tend to be a bit more on the conservative side and would that's why we treated it non-op at first. But I think there's many pros and cons to either, because certainly if you fixed him acutely, you could get him moving quicker.
Yes, but you operated him very soon. Thank you. It was a nice case. I think we need to fly to Buenos Aires, and Gustavo and Diego, I give you the floor. Have 25 minutes, please.
Okay. Thank you very much. Thank you, Ahlam. So we have to finish in 25 minutes.
Yes,
Great.
please, because our
just
colleagues.
to manage. Yes. It's okay. It's just to manage the case. Okay, great. So I'm going to introduce you Diego Espinal. He's a senior fellow of our clinic, of CLIMBA clinic. He's very young and very smart surgeon. So he's going to show us a case of fracture dislocation, so we can discuss some things about the arthroscopic approach. Diego?
Hey, hello, good morning. Hello to everyone. I'm start. Can you see my presentation?
Yes, perfect.
Okay. Oh, hello to everyone. Good morning. My name is Diego Espinal. I'm a senior fellow from CLIMBA, Buenos Aires, Argentina. I come to present a distal radius fracture dislocation. The clinical case is a 44-year-old male, right-handed, that suffered a skiing fall on August 31st. He went to the emergency room where he was at, where they gave him the first aids. He also had a blunt trauma test and contusion and suffered some costal fractures. He presented to us 3 days later with this imaging. He said that they made some reduction maneuvers with this result right here. So do you want to, would you ask for another imaging test?
Maybe Gustavo. Okay. Yes.
Yes. Okay. So we have this patient that it comes to us. Can you show the next X-ray with the cast? Okay, this one. So we have this image, and this patient came to us with the indication of non-operative treatment because he saw 2 surgeons before to coming to us. And what do you think about this, Lucian? What do you think about this case? Do you order another study, or just with this X-ray? Can you show the one with the cast, Diego? Okay, this one. In this case, you don't see any fracture of for the moment, or you don't see any loss of the relations between the bone. But what do you do in this case?
So I don't believe in X-rays in complex traumas. For me, it's not enough. It's like looking at the picture, not in a complete way. So I always do a CT scan. Okay, I would do a CT scan after a reduction in this case, but I always do a CT scan because I want to see what kind of structures are damaged. Sometimes you see only a small thin piece of bone, but we know that thin piece of bone is a ligament. Okay, and for me it's very important because knowing which ligaments were lesioned, knowing what structures are destroyed, we know what will happen with this lesion or this condition in cast. And we know that sometimes in patients that don't get a CT scan, they dislocate again in cast. So it's a very complex condition, and I need a CT scan.
Okay, great. Thank you, Lucian. Somebody
Maybe
does somebody order an MRI?
I would like to say, do you hear me, Gustavo?
Yes.
Yes.
I can hear you.
In these cases, I start with just shortly. I start with a CT scan, and according to the CT scan, I ask for an MRI. We could ask a CT scan and MRI systematically, but in our daily practice, it's difficult for the patient. So 2 steps: CT scan, and after, according to the piece of bones, as Lucian said, after I can ask for an MRI.
Gustavo, I
Yeah.
see you put ultrasound, and I'm a great fan of ultrasound, but I need to say that it's very important that to understand that ultrasound, it's very, very, very difficult in acute cases. Patients have a lot of pain. You cannot do the maneuvers you'd want to do like you do it in chronic cases. So I think that ultrasound is a very good option, but not in acute cases. I wanted only to share this my opinion, but I don't know if you think the same.
Yes, totally agree. Can you go on, Diego?
Okay. We requested the CT scan. We have this coronal view. We can see an interarticular fracture of the radius, plus a non-displaced fracture of the radial styloid and a central subsidence of the fossa of the lunate. On this axial view, we can see a volar and a dorsal fragments with involvement of the radio-ulnar joint, distal joint. And on the sagittal view, we can see the fragments, the volar and the dorsal fragments, and the subsidence of the lunate fossa. And
Okay,
this is specific.
give me a second, Diego.
Okay.
Sanj, what do you think about this injury? That it seems to be pretty good on X-ray, but in the CT scan you can see many things.
Sorry, Gustavo and Sanj, can I interrupt you
Yeah.
1 second? Could you please, guys, ask a fellow about this?
Yes, exactly.
And after Sanj, he can make a comment, please. Just 2 minutes.
Yes. Okay.
Who would like
let me
to
see.
who would like to answer? We have fellows of the Mayo,
Ken.
and we have also
Ken.
Mohammed from go.
Ken Nishimura, how are you doing?
Yeah. Thank you for asking me. Yeah.
What do you think about this?
Japan. Yeah. It suggests that it's very high energy trauma. So I would like to address all the injury as much as possible, and at least we could find that fractures in radius, but I would like to see further in corpus and which type of mechanisms is there, which pathways the energy pass through. So
So Sanj, what do you think about
Yeah, highly unstable injury. And I think, as you said, it was the third opinion that they came to see you, Gustavo, because you can be fooled, right? You've got a great reduction, but remember, an X-ray is a snapshot in time. And if you look at the injury film, you can see the significant soft tissue and bony injury. I think the images that worry me the most are the far right two. You can see that volar ulnar corner lip, but also the impaction more dorsally than volarly. And so I think the areas here to think about is a soft tissue injury, like that whole volar rim ligaments are basically stripped off, but that impaction as well. And so definitely for me, this is an operative case. The CT scan is very helpful to understand the fracture pattern, not for me to determine surgery or not. I think the decision to go to surgery is determined preoperatively with that injury film.
Great. Thank you, Sanj. Thank you. Okay. Thank you, Ken. Can you continue, Diego?
Okay. Right here we can see the sagittal view, where we mark the what is supposed to be the normal
Shape,
contour of
normal
the
shape.
radius, but we can see right here a 4 mm articular subsidence and the displacement of the volar fragment, and that's clearly some signs of instability. Right here we have the 3D reconstruction, where we can see the volar fragment, the dorsal fragments with the comminution, and the non-displaced radial fracture. We can deduce that anatomically we have some that compromises some ligaments. In the dorsal view, we have the dorsal radiocarpal ligament, and volarly we have the radius scaphoid capitate ligament and the long and short radiolunate ligaments.
Okay, so stop here for a moment. Can you go on? I want to see again the sagittal view of the CT scan. Go ahead. I think you have. Okay, this one. Melanie Major, how are you doing? Can you tell us what do you think about the mechanism of this pattern? How it produced these kind of fragments?
I mean, it looks like sort of a high impact impaction type injury to cause sort of the intra-articular, you know, subsidence or step off there, along with kind of the crush mechanism on the volar and dorsal aspect of the distal radius.
Great, thank you. So go on, please, Diego.
Okay. On the following animation, we observe the mechanism by which the trauma produces an avulsion fracture of the volar margin, pulling it dorsally by the radiolunate ligaments and the articular capsule. Then produce an impactation of the lunate on the facet of the radius and the fracture of the dorsal ulnar corner and the subsequent dorsal dislocation of the carpus. This is on fluoroscopy imaging that we made on the OR, where we can see the luxation and the displacement of the fragments that we talk about at the volar rim. Gus?
Can you show again the video? Because I just saw exactly this. You can see that the lunate is going backwards with this little volar rim. So we, as Sanj said, and Melanie and Ken, we have to think about an avulsion of the ligaments. So this is very important. As Lucian said at the beginning, we have to think in this like a ligament injury, not also a bone injury. Okay, so now I want to ask to
we have
Mohammed.
Mohammed.
Mohammed. Okay,
Yes,
Mohammed.
Mohammed, where are you? Because
Mohammed,
he's
how are
hiding.
you?
I'm fine, thank you. I'm not
He's
hiding.
hiding. How are you, Mohammed?
I'm
So,
fine.
what will be your approach to do a surgery on this patient? What kind of method of fixation are you going to bring to the operating room?
First of all, I have to make my mind that this case need for upper adduction external fixation with a specific fragment fixation, plus arthroscopic assisted for the avulsed fragment or any intra-articular depression that need to be corrected. So for me, I will start with the dorsal fragment that to be addressed with a Patras plate. Then after I will proceed with the wrist scope to check for the breast fragment if it's need for elevation by creating a window or through the dorsal fragment before the fixation. And then after I will assess the volar avulsive fragments to be fixed with the suture.
Okay, so you will fix the volar fragment with suture. So you will use anchor for this. Yeah. Okay. Okay. Lorenzo, what do you think about this? What will be your approach with this kind of injury?
It's always a difficult case to treat, but anyhow, in this case, I would probably the most important thing is to stabilize the volar rim of the distal ridges where there's all the radiocarpal attachments. It's the same principle. If you have a radiocarpal dislocation without any bony chips, you have to reattach the ligament with an anchor. So probably I would use an anchor-based repair with the arthroscopic guidance to reattach all the radiocarpal ligament with the bony chips volarly. You can also use a dorsal to volar suture to catch everything and pull back, but for me it's simpler to have a mini open incision volarly and reattach the radiocarpal ligament with an anchor with arthroscopic dorsal view. And then for the rest, for the cartilage impaction lesion, then you make what you can do with the fixation, but it's always difficult with an impaction injury or from the cartilage to realign perfectly because of the lack of suspense and the really tiny chips that you have. But you can use a bony fixation, and then if you want to stabilize everything, you can use some screws to make like an alignment under the cartilage. But this is going to be difficult in this case for me.
Great, thank you, Lorenzo. Okay, Diego, go ahead with the solution that we made.
On the classification side, we can talk about the classic Dumontier's classification, which gives us the two types of fracture dislocation, pure radiocarpal dislocations, and association with radial fractures. We consider this one like a type 2, but it's too ambiguous. There are other classifications, from some of them newer, like the NTM classification. That's a French classification, but we base ourselves on the one done by Dr. Biondi that classifies specifically the dorsal radial fracture dislocations of the wrist. We thought we classified it as a type 3. Okay, about the treatment options, what would you do? We talk about a little bit about that. Do you want to keep going or?
Yes, keep going. Keep going. Okay. Yes.
We have some options. It's obviously a surgical case because the instability of the wrist. We consider some options like plating, like just volar, like a conventional volar plate, double plating, dorsal restraint with suture loop or button, or ligament repair with anchor or sutures, and the use of arthroscopic assistance. In case of considering the classic and conventional volar plating, we have many studies that tells us that it is the gold standard for this treatment of radial distal radial fractures. But in this case, we have a very distal avulsion fragment, and probably the conventional volar plate won't pass the watershed lines, so it's not going to give it contention, and the dorsal ulnar corner might be pushed by the screws. So we can keep with the instability, volar or dorsal instability. About dorsal restraint, we thought about some suture loop or a button. This article is from Dr. Gomez and Dr. Miro about the use of a bottom, dorsal bottom that via transosseous tunnels, you can grab a loop and adjust the dorsal fragment. This could be of use, but in case of comminution of or multiple fragments, it's not going to be of use. We can see that this repairs the diameter of the radius on the sagittal plane, but in this case, we're not going to be able to give contempt. Besides, we're not going to be able to provide stable subchondral surface for the subsidence of the facet. Talking about ligament repair, there's some studies that tells us that the use of anchors in addition to specific fragment plates, like Dr. Kyle, but it is only related with small fragments, and you have to give some bony surface and bony repair first. As we discussed, we chose the double plating for a specific fragment assisted by arthroscopic. In case of the specific fragment double plating, there's several articles that gives us that it is proven to diminish the complication like irritative tendon ruptures. Our objectives were reconstruct the volar rim, the dorsal corner, and give subchondral support for the central sink. So this is what we performed. We placed a hook plate at the volar side we put just we went with a proximal screw. After that, we placed a specific dorsal ulnar plate with a proximal screw. This is the avulsion, the volar avulsion of the rim. This is the hook plate position with its proximal screw. And this is the dorsal view with the dorsal ulnar specific fragment plate. This is how they were put, just with the proximal screws. After this, we went to the arthroscopic time, where we reduced the fragment, the subsidence fragment, and we gave support to it with the distal screw on the dorsal plate. And then we put the rest of the distal screws. This is an arthroscopic view where we can see the instability of the surface. We performed see.
Sorry,
Yep.
go to the end of the video because we are short of time.
Okay.
Just here. Go ahead from here.
This is the image when we were progressing the distal screw. This is the result with fluoroscopy on the OR. And this is a one-week control. We also solicited a CT scan the first week, and this is the result, the comparative result. We have the reduction of the dorsal ulnar corner and the contingency of the facet fossa, articular facet. On this view, we see the reduction of the articular surface and the reduction of the volar rim fracture. We also see how the hook plate keeps the volar fracture on site, anatomically on site. And we can see in this coronal axial view how the radioulnar distal joint is anatomical. This is 8 months post-operative. He has a complete range of motion, and he went back to regular lateral and sports activities. As conclusions, we can say that we have to properly assess the distal radius fracture dislocations. Sometimes there are ligaments involved that are underdiagnosed. That's where some extra studies have to be solicited, like a CT scan, or in some cases like MRI. Like as a tip, as a pearl, we have to think that when we have large bone fragments, we have to use plates, and with small bone fragments, we have to use anchors or suture, or we could combine some of them. And arthroscopy gives us an anatomical reduction of the joint.
Okay, thank you, Diego. I know that Sanj is short of time, so I want to hear your final comment, Sanj, please.
Yeah, Gustavo and Diego, outstanding case, and thank you for always teaching us. I mean, you are a world-class arthroscopic surgeon, and I mean, that's a tough case. Just a comment. When I've done these, I put a bridge plate on as well because of the ligamentous healing. You know, it takes at least 3 months. So typically, I would add a bridge plate. But I wanted to ask you a technical comment. The volar, you made a nice reduction volarly. When you went dorsally and put that plate down dorsally, did you put the proximal screw all the way down, or did you have it off the shaft a little bit so you didn't sandwich those dorsal fragments down? Because once the plate is down and then you do arthroscopy, it can sometimes push it down. So I found that you needed to put the plate down, but not all the way with the proximal screw, so it's moving a little bit, so then you can disimpact the fragments and then screw it down. So just a technical word on that, please.
Exactly. This is a very important point, because when we place the plate, if you compress a lot these plates, the fragments in the middle of the joint will be stuck inside the joint. So it's very difficult to unimpact this fragment and to reduce the articular surface. So as Sanj said, and this is very, very important, do not compress the plate before doing the reduction. Just place the plate, put the dynamic screw without finally compress the plate, and then you reduce the fragment by arthroscopy, and then you compress the plate. Okay, this is a very, very, very important point that Sanj highlight here. Very, very good, very good. Thank you very much, Sanj.
Thank you, Sanj, for the comment. Thank you, Gustavo, Diego. The case was really wonderful, as usually the 2 cases. Thank you for preparing the cases, David and Diego. Maybe next time we will have a delayed presentation of the same case, and we will discuss about this. It's also a good discussion. And I wish you a nice day in Rochester and Buenos Aires and in Roma as well. Thank you all, and see you very, very soon. So it's very nice to see you all. Thank you.
Thank you.
Thank you for the discussion.
Bye-bye. Thanks.
Bye, everybody. Great webinar.
Bye.